All right, I see we are at 10:01 and we
Right.
have almost 50 folks in the attendees space. So welcome to all of you. Thank you for joining us. I'm Jenny Weir. I'm going to do a quick intro and then hand this over to Sharon. So you are all on mute and you will be throughout the day. Please write any questions in the Q&A box and any technical issues into the chat box. We will be looking at both throughout the webinar. This webinar is also being recorded and we will post it on our YouTube channel along with our slides after the webinar. All right, Sharon, the floor is yours.
Excellent. So thank you everyone for attending. As Jenny mentioned, you are currently participating in the Change in Action webinar series part 3 for this year, brought to you by the Foundation for Healthcare Quality and the Washington Health Alliance. And today's topic is aligning quality measurement, measuring what matters. Next slide, please. I want to talk a little bit, introduce myself. I'm Sharon Elaranta. I'm the Medical Director for Performance Measurement and Practice Transformation at the Washington Health Alliance. Next slide, please. For those of you that may not know, the Washington Health Alliance is a membership organization comprising purchasers, providers, health plans, and consumers, and has been working since 2004 to bring those partners together to increase the value of healthcare provided in Washington State. This is just a small selection of some of our members. Next slide, please. The Washington Health Alliance has 3 main functions at this time. First, we are a trusted convener, bringing together all of those different stakeholders to try and get folks on the same page is a large part of what we do. And the work of our membership drives all of our work. We also promote transparency. So it does take that type of trust for medical groups and clinics to trust the process and allow us to publish on our website unblinded results for a variety of healthcare indicators. And finally, we drive action. So you can put all the data out on the web that you want, but if no one is using it and not trying to make things better or asking questions, that's only part of the work. So we bring people together to implement change. Next, please. Speaking of the data, I just want to make a quick pitch for our latest report, which is total cost of care at the medical group level. Go to wacommunitycheckup.org and you can see all of our reports, but our newest one then is total cost of care, not only at the geographic level, but at medical group and clinic. So if you're interested in how you're performing or you're in your region, you can find that information there. We'd love feedback. Next. Jenny?
Thanks, Sharon. So the Foundation for Healthcare Quality has been really fostering collaboration and working across sectors in our community since the late 80s. Our mission here then is to bring people together who don't usually talk around this cross-organizational health and healthcare provider, administrators, those with lived experience space. We work with chart abstracted data, consensus building, feedback, and evidence-informed best practice. And then our home to 4 care outcomes assessment programs. You'll see them listed here, focused on cardiac care, surgical procedures, spine surgery, and then obstetrical care, as well as the BRE Collaborative, the Patient Safety Coalition, and Smooth Transitions. And we are very happy to be in this partnership with the Alliance, focusing on value-based payment.
Next slide, please. So why are we here today? We are here because in the state of Washington, as in many places across the country, we're in the middle of this transition from fee-for-service payment for healthcare to value-based payment. So fee-for-service is basically folks get paid for each service regardless of the quality, and there's an incentive to basically do more to value-based payment, where the provider is paid for providing high quality and high value care to the patients. Next. So Washington State has defined our value-based purchasing standard going on kind of a scale from category 1, which is just regular old fee-for-service, no link to quality and value, moving toward category 4, which is an evolution to population-based payment. At this point in our state, we feel we're kind of at category 2C in which we have pay for performance, where there are bonuses for quality performance. But our goal is to move forward all the way through category 4C, which is the true integration of finance and delivery systems. And we'll be hearing more about Washington State's efforts in this way in just a few minutes. Next, please. A few years ago, the Healthcare Authority and some others did some work to try and determine what stakeholders around the state felt were either drivers or challenges to this goal of moving from a 2C to a 4C type of a system in our state, and kind of curated this out to what the topics of our webinar series have been. So these are working with the social determinants of health, interoperability, so that healthcare providers and community-based organizations across the system can communicate well with each other to assure smooth, continuous care. Shared data definitions, and that's where we are today, talking about metrics, how data are defined and used, and then multi-payer initiatives. Last year, there were 4 webinars, one each on these themes, and we are at number 3 of 4 for this year's series. Next. So we're also asking that all participants in our webinar series pledge to take one meaningful step in 2022. So what will you be working on? Social determinants, interoperability, aligned quality measurement, or multi-payer strategies? Next. So this is my little soapbox slide, and I apologize for that, but so the problem with metric myopia, we're all just like looking so closely at our metrics that we can't even really see them anymore. Our system currently has multiple purchasers, so your employers, your union trusts, and others, and the state, working through multiple health plans and other intermediaries, creating value-based payment initiatives and contracts that have highly variable metrics between them and performance expectations. The result at the provider level tends to be confusion, burnout, and of course, as is often, I think, wrongly attributed to Don Berwick. He would say he didn't coin this, but every system is perfectly designed to get the results it gets, and we know we are still not performing at the level of value that we hoped for. So what can we do? In the next slide, we'll talk about our learning objectives. So when we finish up this program today, you'll be able to describe how federal, state, and commercial payers and purchasers integrate their metrics into their value-based programs. You can list 3 challenges encountered by providers in coping with varying metrics used in these contracts. Discuss how the stakeholders can work together to align metrics to enable value-based care. And then think about how everyone, all of us, contribute to meaningful change, providers, health plans, and purchasers, and what is realistic for us to hope to achieve. We also want to remind everyone that for these webinars and in all of our work across both sponsoring groups is that we do nothing without applying an equity lens. An equity lens, and this is more of a policy definition, is a process for analyzing or diagnosing the impact of the design and implementation of policies on underserved and marginalized individuals and groups, and to identify and potentially eliminate barriers. So as we think about metrics, the choice of metrics and how they are implemented, we need to keep that equity lens in mind and make sure that we are not promoting things that may result in unintended consequences. On the next slide, we have such a great agenda. I'll be done in just a second so we can get to it. Our lineup of speakers include Tamara Garcia, who is the Deputy Director for Quality Measurement and Value-Based Initiatives at CMS, Dr. Emily Transu with the Washington State Healthcare Authority, and what should be a really promising panel discussion with Dr. Edwin Carmack of Confluence Health, Dr. Andrew Sparks of United Healthcare, and Dana Weatherly from Alliance Surgeons. Next. And with that, I am very excited to introduce our first speaker, Tamara Garcia. Ms. Garcia is a results-oriented public health professional with over 20 consecutive years of service. More than 12 of those years have been with the Department of Health and Human Services as a public servant. Her skills offer a unique combination of analytical knowledge, policy development, and strategy implementation. Her public health and policy experience vary in scope. She has collaborated with non-governmental organizations in the Dominican Republic to examine the quality of care provided to patients at a maternal and child health clinic. She's also worked as an epidemiologist at CDC and more recently translated her analytical ability to shape, guide, and implement national policy to improve the lives and quality of care received by Medicare beneficiaries at the Centers for Medicare and Medicaid Services. As a Deputy Director of the Quality Measurement and Value-Based Initiatives Group, she works with over 122 professionals to incentivize quality of care across the nation. She graduated from Spelman College and obtained her master's in public health epidemiology from Columbia University. Her passions include social justice, maternal and child health, and infectious disease epidemiology. Thank you very much for joining us, Ms. Garcia.
Thank you so much. That was an extremely comprehensive bio. I'll have to thank my special assistant for that. But I'm very happy to be joining you all today. Good morning to you all. And I always like to set the stage at the beginning of the discussion, and we can move to the next slide. With that being said, I want to give you all just a very high level of our 3 primary objectives for this morning. So the first is to really share a bit about the Quality Measurement and Value-Based Incentives Group as an organization, what our priorities are, what our portfolio of work is. The second is to really expand upon that context, to provide insight around how we really make decisions around our priorities, how we determine what measures and measure concepts are most essential for advancing quality, and what's most appropriate for our pay for performance and pay for reporting programs. And then finally, I want to conclude today's discussion with a really quick preview into our efforts to promote equity in the inpatient hospital setting. I'm going to describe at a very high level some measures that we've proposed in our proposed rule, as well as a request for information that we really displayed within the rule to sort of glean information from folks around what's important to them in the context of measuring and understanding the impact of different risk factors, social risk factors on the outcomes of our measures, measurement, and also to figure out where to target quality improvement care. So who are we? And I think this slide here really begins to kind of provide some insight there. At our core, the Quality Measurement and Value-Based Incentives Group, we refer to ourselves as QMVIG, is an organization within CMS that really seeks to improve healthcare quality and safety for all individuals. And so the quality component is there, the safety component is there, and then our commitment to equity is really demonstrated in that all individuals language. Now, a lot of folks do that, right? So what really separates us from others seeking to do something similar? Well, that would be described within our vision. Our vision really focuses on the levers that we have within the Quality Measurement and Value-Based Incentives Group to promote quality healthcare. That refers to our measures, our statutorily required pay for performance or VBP programs, our pay for reporting programs, and also our public reporting programs as well. And so our desire is to really sort of collaborate with folks, provide transparent information, whether that's directly to providers or to patients who leverage this information to make informed decisions about their quality care. And we really want to be a national leader in this. And we believe that we are, but we really want to continue that work. Next slide. So the way in which we execute those programs and those levers that I just referred to is really rooted in our strategic focus. And so for this administration and our administrator, our CMS Strategic Pillars really fall into 6 primary categories. And these categories include advancing equity, which you see here first, expanding access to care, engaging our partners. We talked about partnership and collaboration within our vision, really driving innovation, right? What do we need to do to address the challenges that we're currently experiencing around data submission burden, around access to timely, accurate data? How can we make this information more person and patient centered so that folks can access information in a timely fashion in a way that resonates with them? And so how are we moving to the 21st century with respect to those things, right? How are we protecting our programs? And that really lends to us being able to continue to serve as the largest health insurance company on the planet. But not only that, are we providing quality care with respect to that access? And then finally, fostering excellence, which is really more of an internal goal around workforce and operational excellence. So these pillars are actually one of several inputs that really contribute to our strategic goals, which you see in this slide here. And these are the goals of the CMS Quality Action Plan. So while that last slide there really spoke to generally what we're looking to do as an organization, this slide here really focuses specifically on quality. And so this quality work here, these 5 pillars that we see, do involve the entire agency, but it creates more specificity around what we're doing specifically in the context of quality. And they're really parallel in nature to what we described in our vision. So the concepts include meaningful measurement. Are we ensuring that the measures that we're selecting for our programs to incentivize quality care, to publicly report, are they meaningful? Do they resonate? Are they moving the needle of quality forward? Are they advancing quality and equity? The second is really focused on using measures and transparent data to really incentivize quality care. The third really focuses on that push to transition quality measures to the 21st century and to the digital age. So it's around promoting interoperability, really solidifying what standards we're leveraging across the healthcare continuum so that we can more appropriately coordinate care, those types of things. And in doing that, reducing burden, giving ourselves access to that real-time data so that we can make decisions about where to target care and, decisions around how we can really publicly report information for folks. And then finally, this last goal here is focused on engaging patients to empower them to leverage these tools for healthcare decision-making, as well as the promotion of equity to close gaps in care. Next slide. So measurement has been an essential theme here as we've talked through a lot of these high-level strategic pillars. And at its core, it's really the most compelling tool that we have. So we're going to talk a bit more about measures and measurement within our group. But how are we really using these measures, and what are we doing to optimize our ability to develop those meaningful, impactful measures that we discuss, measures that resonate with patients and do not result in undue burden to providers? And so this slide here describes those activities. And one of them is really alignment and consolidation of modernized value-based programs. And we're going to talk a bit more about just sort of the breadth and the scope of value-based programs that we have at CMS. The second is really aligning quality metrics. So not simply aligning the programs so that they are as simplistic but impactful as possible, but aligning the measures. Are at the data element level and the specification level, are we sort of aligning across all of the different layers of data reporting so that folks aren't reporting slightly different measures to different programs based on different requirements? The third is really an increased focus on the consumer. So that's ensuring that we are engaging in human-centered design to focus more on the patient's needs. When they go to look at our programs on Care Compare, for example, is it displayed in a way where they really understand what they're looking at and they can make decisions based on that? Next, we're thinking about innovative ways to use data within the agency, advance analytics to build better measures, inform healthcare decision-making, target quality improvement initiatives. And so this transition to FHIR so that we can really look at information from the data element level and maybe have advanced analytics or AI, calculate the measures as opposed to doing it system by system. So we're really looking to evolve this work over time to reduce burden and to really create an environment where folks can use this information in the way that it's intended. Next slide. So this slide here, shows where we're doing all of this work. And as you can see, we have quality incentive programs across the healthcare continuum. We have 3 columns here where we sort of list the full gambit of programs at CMS that look to promote quality. These are both fee-for-service, Medicare, as well as Medicaid programs as well. And we have them in the hospital setting, including inpatient and outpatient hospital settings, outpatient hospital departments, the ambulatory setting. So I know many of you are familiar with the merit-based incentive program, as well as some of the public reporting programs around hospital stars and the Support Act program, which requires folks to submit electronic scripts that fall into a certain classification, specifically drugs that fall into the opioid classification. And then we also have several programs in the post-acute care world as well that cover several different settings and facility types. And so some of these programs are what we refer to as pay for reporting. And these pay for reporting programs, they really assess or examine performance on the measures that fall within that program. If you do well on the measures, in some cases, you receive a bonus depending on how the program is specified by statute. If you do poorly, you tend to receive a penalty. And there are some programs where you don't receive a penalty or a bonus. You simply maintain and are able to receive in full all of the claims that were submitted for the care provided in any given year. Others are pay for reporting, excuse me. So those pay for report performance programs here are denoted in the red font. All of the other programs are what we consider pay for reporting. So as long as the data submitter, the folks who are eligible to participate, are actually submitting data and reporting on the measures, they receive credit for participating in the program. Some of these programs have been around for several years, while others are new, and the new programs are either new versions of themselves. So they've been expanded to larger programs, and that is exemplified by this expanded SNF VBP. SNF VBP is Skilled Nursing Facility Value-Based Purchasing Program, statute that was actually passed at the beginning of 2021, indicated that the current SNF VBP program that included one all-cause readmission measure, we needed to expand that program to include at least 9 additional measures. So we're expanding that program. Another program that you see here with a star next to it is the Rural Emergency Hospital Program, which we're very excited about. It came out of a similar legislation. So we're working to begin to implement and identify the measures associated with those programs. And in future rulemaking, we'll sort of spell out specifically what the requirements are. So there's more to come on those programs, but we're deep in sort of preparation for many of those. All of these programs, as I stated, are required by statute. So the Senate, they make decisions about what they think is important and provide very high level specificity around what's needed for this program to exist. They provide us the authority. And then CMS, you know, we do research, we delve deep, we engage with external stakeholders to determine exactly what the program should look like. And so the regulations that we write are really establishing the measure sets and spelling out the requirements for these statutes that are released out into the country. And so each program has very distinct characteristics because each of them are connected to a specific statute. Some of them require pre-rulemaking cycles, where before we actually decide to write a regulation and propose measures for the program, we have to go through a process with the National Quality Forum and our Office of General Counsel to really sort of ensure that the measures are valid and reliable enough for inclusion in the programs. And so that's a very, very involved and fruitful process for us. Next slide. So not only do the programs vary, and not only are there very many of them, which you saw in the last slide, but the measures that make up these programs are quite diverse in nature. And so this slide here really examines the types of quality measures that we see within our programs. And it organizes them by the type of burden associated with data submission, with claims being the least burdensome measures to submit into these programs, where and hand or chart abstracted measures being the most burdensome. So all of these other measures types fall somewhere in between, with cost measures that really examine value being slightly more burdensome than claims measures. Digital measures, which we are very much interested in sort of growing more of these over time. Hybrid measures, which are typically a mix between pulling some data elements from digital systems and maybe some claims measures or some other hand abstracted measures collectively together to form a hybrid measure. So it's a bit of both. PROs are patient reported outcome measures. So that's patient experience focused measures, where we're going directly to the patient and gleaning information from them regarding the care that they've received. Composite measures, which includes several measures to kind of formulate into one sort of summary measure, I guess is the explanation in lay terms. And then there are, of course, those hand abstracted measures. So those many different types of measures exist within our programs. Next slide. So CMS takes each of these measures based on those statutory requirements for our programs through what we described as a measures life cycle, which begins at conceptualization. And so conceptualization is really where we pull information from several inputs, which contribute to our, I would say, internal strategy, an internal priority focus. We tend to share at a very high level what these priorities are through our meaningful measures initiatives and other sort of public facing discussions. And so many folks really understand what we're looking to achieve here. There are staples like patient safety, and then there are others which over time grow in more prominence and visibility. And that a great example of that is some of the work that we've been doing around maternal health. And so once we determine conceptually what measures we're looking to develop, then that evolves into the next stage, which is really the specification process, where we begin to craft the characteristics of the measure and we test feasibility of developing and implementing that measure. Then testing is ramped up to ensure validity and reliability. And it's during this phase that measures are actually taken to the National Quality Forum, where they're reviewed and considered for potential endorsement by several work groups that really look to determine whether or not they believe this measure will contribute to incentivizing quality care, whether or not it's testing what we intend it to test, and whether or not it can be leveraged for, payment decisions. And if all goes well through all of these initial processes, we will propose the measure in a rule and potentially finalize it. Then begins work around the implementation phase, where we're actually implementing the measure. We're rolling it out because it's completed that process. And then we continue to evaluate and maintain that measure as it lives within the programs. This process takes anywhere from 2 to 3 years to happen in full completion, depending on whether or not it's developed ahead of some of those National Quality Forum activities. Next slide. And so I think one thing that folks are very interested in knowing typically is, how is a measure even considered for the conceptualization phase, right? And so as mentioned previously, there are many inputs that contribute to our measure concepts inventory, which was, we refer to it as that. We take into consideration the patient perspective. We engage stakeholders in listening sessions to obtain feedback. We also hold technical evaluation panels where folks can nominate themselves or be nominated by an organization, and then we form these panels to really inform this work. We also engage in data and analytics work to really determine how the measure should be specified and what the concept should look like. We do environmental scans and research, and a lot of it also comes from our larger strategic priorities, which we summarized earlier in the presentation. Next slide. And so there are over 900 measures, and these are just some tools that help us keep track of those measures. I can provide links to folks who want to access these. One is a CMS measures inventory tool. We refer to it as the CMIT. It has thousands of measures in the CMIT where folks can access information on where the measure is from a phase perspective, whether or not it's endorsed by the National Quality Forum, et cetera, who the steward is for the measure. So this is a very helpful tool. The second is the Quality Measure Index, and I can actually talk a bit more about that in the next slide. The Quality Measures Index actually helps us to evaluate our measures before we begin to really sort of integrate them into programs. It is a tool that really looks at standard quantifiable characteristics around the measure to determine whether or not it's meaningful. Other things that we look to evaluate our measures is, of course, the National Quality Forum seeks to endorse every 3 years. We have sort of internal guiding principles that we use to determine whether or not the measures are impactful. And again, we leverage that QMI resource. Next slide. So now that you understand more about who we are and how we leverage quality measures to incentivize care, we want to do a quick dive into some of our activities to promote health equity. Next slide. And so again, I love to begin with context. So I wanted to share this slide to truly illustrate the importance that health equity holds at the agency level. And so while our ultimate goal is a health system that achieves equitable outcomes through high quality, affordable, person-centered care, you can see that advancing health equity is mentioned again in that second bullet there, right below that larger piece. Next slide. So one challenge that we had in terms of beginning our efforts to advance and promote equity within our programs is being as prescriptive as possible regarding what we were seeking to achieve. In other words, we needed to determine really truly actionable objectives and also, more importantly, how we define health equity. And so in this slide, we wanted to clearly signal that we want to advance health equity by addressing health disparities that underlie our health system, but that we also define health equity in alignment with the executive order issued by President Biden in 2021. And we define it as the attainment of the highest level of health for all people, where everyone has a fair and just opportunity to attain their optimal health regardless of several sets of characteristics: race, ethnicity, disability, and that all of these folks have access, effective access, quality access to care and health outcomes, positive health outcomes. Next slide. So at the agency level, these are our actionable goals. And they range from evaluating policies to ensuring we are supporting providers that serve at-risk populations, the collection and use of data around determinants of health. And so this is just a reference slide for folks to take a look at those actionable objectives from an agency perspective. And the next slide really delves down into a further refined CCSQ, the Center for Clinical Standards and Quality Health Equity Strategic Plan, where we are a bit more prescriptive around a quality focus around these actionable objectives. Both of these slides that we just showed are very ripe with information and can be used as reference materials to provide insight around current and upcoming objectives. Next slide. So from these larger strategies, we distilled very specifically how we can leverage value-based programs to promote equity and determine what we should commit ourselves to. And these 4 activities are a quick summary of that. So we wanted to develop a standardized approach to collect data to promote health equity. We want to think about how we want to stratify measures to give folks insight into where they should potentially target care based on their organization. We want to leverage IVBP programs to publicly incentivize positive health outcomes for everyone. And we also want to support equity through performance metrics. And the next slide is our most recent efforts around that work. So next slide. This slide actually summarizes at a very high level one of the 2 activities that we've engaged in the inpatient prospective payment system proposed rule to really sort of begin to execute our strategy around promoting health equity. So the 4th pillar there that we had on the last slide really focused on metrics and the development of measures to promote health equity. And so here we're proposing 3 measures, one of which is a structural measure. And this measure is an attestation measure, but it really focuses on ensuring that organizations are engaged and focused on achieving health equity across racial and ethnic groups, people with disabilities, members of the LGBTQ+ community, and people facing socioeconomic challenges. And so the goal here is to ensure that organizations are taking a step back and looking at what they're doing in order to promote positive health outcomes, equitable health outcomes for the folks who fit into these groups. The second 2 measures are actually related. They're screening measures for social drivers of health. And so the first measure is really focused on whether or not folks are assessing screening for food insecurity, housing instability, transportation needs, et cetera. And the second is just a reporting measure on understanding the rate of folks who test positive for needs around insecurity, instability, et cetera. So we are in the process of collecting comments on these measures. And in the final rule, which will be displayed in a few weeks, folks will see whether or not we are continuing to proceed with these proposed measures. The next slide summarizes our request for information that is also in the inpatient prospective payment system rule. And we sought feedback because we're still sort of in the information collection phase for some of those objectives that we listed on slide 18, where we're really seeking feedback on how we could use and leverage information on stratified measures to assist hospitals with creating actionable and comprehensive action plans based on these data. And so we're very much interested in hearing back from folks on that and look forward to the information that we glean. Last slide. So I just want to thank you all for your patience and listening to the discussion today. I know it was a lot of information. If you all have any questions, please feel free to reach out to me. That's my contact information. And I'm very excited to participate in the rest of the presentation today. Thank you.
Thank you for joining. And we do have one question before we move on to Emily from Doug Conrad. A lot of the measures refer to hospital or ambulatory surgery settings. Is there a parallel quality measure alignment effort focused on physician practices?
Absolutely, absolutely. So in some of our strategic work around the ambulatory setting, we have attempted to be extremely creative in using different levers to promote health equity. And so the MIPS work is very interesting in that we have quality measures, we have MIPS to value pathways, we have improvement activities. And so we want to leverage every lever possible in order to promote health equity in those areas. We're not limited to measures. And so as folks begin to see more information come out around the proposed rule, and are able to provide their comment on it, I think they'll be happy to see that we are sort of trying to take a comprehensive approach and are looking to develop parallel measures, or at least measure concepts in other settings.
Great, thank you. All right, turn it over to Denise.
Next slide. And I'm happy to introduce Dr. Emily Transu to you from the Washington State Healthcare Authority. Prior to joining the Healthcare Authority, she was a primary care physician. And I also learned that she has published 2 books, one on call, a doctor's days and nights in residency, and the other patient by patient lessons in love, loss, hope, and healing from a doctor's practice. So that was fun to learn about you, Emily. I turn this over to you now.
Wasn't expecting that particular component. Hi, it's so nice to be here, and always just such a pleasure to be part of these conversations. There are a million things from Tamara's discussion that I wish I could build on, but I'm going to try to move a little bit concisely here so that we can get on to our panel. So I'm going to talk a little bit about the Washington State Common Measure Set, and specifically how the Healthcare Authority is using that, and what impact we're seeing, trying to kind of get a little bit more practical into some local results that we have seen from alignment efforts. I can go on to the next slide. So there's been some discussion previously about the Common Measure Set in this forum, so I'm not going to go exhaustively into that. But this effort really kind of started in 2014. There was legislation. Washington had a state innovation model grant at the time, and that legislation established the Performance Measures Coordinating Committee, or PMCC. I will apologize for the number of acronyms in this presentation. It's what happens when you work for government. The goal here was really to reduce variation and administrative burden and get the state focused around key priorities. And I think we've heard over and over again, you just can't be a provider trying to do 60 different quality measures and slightly different definitions from here and there. So this is what the PMCC was created to do. And they established the first Washington State Common Measure Set. It started out as 52 measures. It's now 60. Some of you are raising your eyebrows and saying, but you just said you can't do 60. Something I would say is these are in a lot of different domains, as kind of came out in Tamara's talk. So if you're looking at primary care measures or outpatient measures, it's a much smaller list than that. And again, really the goal here was to kind of get everybody focused on.
Emily, you are muted. Or you've become muted. Perfect.
Sorry, when did I lose you? The PMCC is convened by the Washington Health Alliance and the HCA, but consists of stakeholders from many different areas of healthcare in Washington State. So started with these 52 measures, and then that's continued to evolve over time, as all measure sets do. And again, some of the same themes that Tamara talked about. Measures come and go. We don't develop measures as the PMCC or HCA. We follow ones in general that are done by other stewards. So as a PETUS or NCQA changes a measure, gets rid of a measure, that's going to need to become off the measure set. There are new measures, that discussion around digital quality measures, which we're all really excited about. Other kind of new ways of measuring, as well as new things to measure, evolve over time. And then the state priorities and areas of focus evolve. So this is always going to be a living measure set. It's always going to need to have things added and things removed. And that's really as it should be in this space. On to the next slide. So what does the Healthcare Authority do with the Common Measure Set? And for those who don't know, HCA is the purchasing authority for Washington State for Medicaid and public and school employee benefits. So collectively, we insure about a third of the state. What do we do with this list? Really, it is our North Star of selecting measures for use in our contracts. And that includes reporting. So For essentially all of our contracts, we require reporting of the relevant measures. So we're not going to ask a health plan to create a hospital measure, et cetera. But for the health plan relevant measures, we require reporting from the Medicaid MCOs, pattern subcarriers, Cascade Care contracts more recently. And then more importantly for today, this is the set that we use for value-based purchasing. So we will always use measures from the common measure set for VBP with the caveat that there could be a compelling reason not to do so. So currently in our VBP measures, there's one that isn't on the common measure set. That's within our foster care contract. It's a lead measure. Lead poisoning is pretty low in the state. Just historically, there's not a lot of lead exposure. And it's kind of actually an interesting example because the common measure set is created to look at statewide really common issues and thereby limit the number of things. But there will be occasional times when you really want to look at a very specific problem to a smaller population, and there the common measure set may become a little bit less relevant. So foster kids have about 3 times the lead exposure in general of other kids. So that's a place where this sort of small group needs something a little different. But otherwise, we're always going to be drawing from the common measure set. So that's going to be the managed care organization measures. That's going to be our public and school employee benefit carrier contracts, our accountable care program contracts, also our involvement with the multi-payer primary initiative. So we are really always drawing from the common measure set as we incentivize things, unless the rare case where there's a compelling reason not to. On to the next slide. So how do we identify and select measures? And this is a very similar list for what HCA does in selecting things from the list, and also what the TMCC does in selecting measures for the list. And a lot of this, again, echoes themes that you heard from Tamara a moment ago from CMS. So we really think about, is a given measure, does it have potential to impact health outcomes? Does it have potential to impact equity? Can we align across state contracts? And this, I think, idea, that's the central idea today, alignment, alignment, alignment. How do we minimize the administrative burden of measurement? It's always going to be a little bit of a burden. Sometimes it's a huge burden. How can we get the best value out of the least burden possible? How do we avoid unintended consequences, especially for vulnerable populations? So, for example, there are certain contraceptive measures that everybody is excited about on some level, but could be used in certain situations as a kind of drive toward coercion to push people to select certain options. We always want to avoid that kind of danger. And then we really, again, want to consider opportunities to align, whether that's with other state programs, whether it's with national priorities. So this is kind of how we think about measures as we're choosing what to do. I'm going to focus a lot more on our managed care organization contracts because I think that's a really interesting area, and one where we can talk a little bit about the kinds of results that we've seen. So we introduced value-based purchasing into our managed care organization contracts in 2017. The way that we implement this was modified pretty significantly by a budget proviso from the legislature in 2019. And essentially 2% of our payment to the managed care organizations is at risk for performance. Of that 2%, 25% is returned to them based on meeting goals for including DBP in their contracts with providers. So HCA's got contracts with the MCOs have contracts with providers, and we ask them to include DBP components in those provider contracts, kind of pushing this whole idea through deeper into the system. And that component follows the HCA value-based purchasing roadmap, which I'm not going to spend time on today just for time reasons, but that's the piece that is looking at how are we really moving from those lower laying categories of pay for reporting up through pay for performance, and then driving into those kind of higher level subcapitation, et cetera, kinds of arrangements. So they had this 2% withhold, 25% of that is based on whether they're doing DBP with their provider contracts. And then the other 75%, which I'll focus more on today, is for performance on quality measures. This budget proviso gave us some very, very specific instructions on how to select and implement those. So it's 7 measures for each managed care organization. And they earn back that withhold based on the proportional number of measures that either improved statistically significantly from their performance the year before, or scored in the top national Medicaid quartile. One of the challenges always with VT is how much do you reward improvement versus how much do you reward overall attainment? And you really kind of want both, right? Because if you've got somebody who's performing at the 20th percentile, you don't want to say you got to get to the 75th before we give you anything for that, because they're just gonna, it's not worth their while probably to have to make that big of a jump before there's a reward. And on the other hand, you really want to be able to continue to incentivize people who are doing well. So this really allows one or the other, either really good performance or improvement. How do we get to those 7 measures? Again, this is specified in the budget proviso. So it specifies there are 4 that are common across all the MCOs, at least one of which has the potential to impact costs, and at least one of it has the potential to impact population health. I think some of us who really live in this space would argue that all of these measures impact population health, or they wouldn't be on the list. But the legislators who were creating this had a slightly different viewpoint. Then 3 that are specific for each MCO. So 4 common, 3 that are distinct off the common measure set, and here really reflecting areas where that MCO is not doing very well. And again, that they be substantive and clinically meaningful in health status. I would say the population health piece and the substantive and clinically meaningful are something we look for in all of our measures. We're allowed to have up to 2 homegrown measures. So the DSHS Research and Data Analytics Group has created a couple of measures for the state of Washington around penetration of mental health and substance use services. So we're allowed to have up to 2 of those. So these are the rules that we are given by the legislature in selecting these measures. We can go on to the next slide. We do this annually, and HCA works with Comagin, which is the External Quality Review Organization, or ECRO, for Apple Health or Washington State Medicaid. They look at the data, they advise and work with us on selecting these measures. And we've really pushed a couple of things within those proviso requirements. We've really tried to have relative stability over time. I think one of the challenges with incentivizing measures is if you change them, if you just keep changing them year by year, you know, we're changing what's in the MCO contract, they're changing what's in the provider contract, the providers are trying to figure out how they're going to respond to this new measure and what systems do they put in place in their organizations. It takes time to make a difference. So we've really tried to keep them relatively stable and also to align them as much as possible across the MCOs, because that underlying theme, I think, through all of this of if you focus on a limited number of things, you'll get change. If when I'm in clinic, if I'm sort of getting, well, there are these 7 for this MCO and there's these 7 for this MCO, and it can add up to a lot, even if 4 were in common, if the other 3 were all different, we'd have people going in more directions than we'd like. So we've tried to keep that total list as slim as possible, and almost across the board, we've been able to keep it the same for all of the MCOs in any given year within the proviso requirements. So what does that amount to? And don't worry, I will not go through this slide in a lot of detail, but this shows the years, the measurement years since this first kicked in, and the measures that have been incentivized over that time. The proviso kicked in 2020, it was done in 2019, kicked in 2020. So we'll see a graph of this in a second, but you'll see that there have been some measures that have been constant throughout. There have been some that have come in over time and some that have gone out over time, whether because they didn't meet kind of those standards anymore or because there was a change in the definition. So for example, the child and adolescent WellCare visit, that was changed by NCQA as a measure steward. So out of all the universe of measures, we've been able to kind of get it down to this set, which is all from the common measure set. And then seeing that graphically on the next slide, you start to see the impact of this. So this is how things have changed since we first brought these measures in as incentivized measures. And what I'll point to is that really there's some variation, of course, but overall you really see an upward trend in the performance on the incentivized measures. I won't go through each of these individually. You can look at them in detail later. But in general, we've really seen a quite significant impact on performance in the measures that we've incentivized. And although I can't, I don't have non-incentivized ones to compare to, most of the time, when we haven't had this, we're really not seeing this kind of rise over time. So this has been very exciting for us to see big changes in performance over time. On to the next slide. This is just for reference. This is the kind of information that we put out there for those of you data geeks who really want to get into this. This is all published in our comparative and regional analysis for our MCOs. So you can see how are they all performing, what's going up, what's going down. We've got a lot of detail out there for those who are interested. And on to the next slide. Is the VBP in our MCO contracts the only thing driving this? No, we've got other things going on. We've got performance improvement projects around the well-child visits. We've got an asthma affinity group meeting on asthma. We've changed the frequency of refills you can get. There's lots going on. And that's kind of the point, right? The point is focus the state around areas of priority and bring lots of things to bear on that so everybody's pulling in one direction. That does complicate, of course. It's, you know, we can't say this is the only thing that changed, so this is the only thing that's responsible for improvement. But that's kind of okay, right? The idea is alignment. On to the next slide. So what are we going to do next? You know, as there are areas that are doing so well that we really don't need to be incentivizing them anymore, we'll take them off. We're looking a lot at alignment with other programs. One in particular for this contract is alignment with the multi-payer primary care initiative, and also really looking at that equity focus. And I think Tamara spoke to that beautifully. Next slide, which is close to the last one. Oh, this is just a list. Alignment, the problem with alignment is if you get into alignment with one thing, you're pulling out of alignment with another thing. So it's a double-edged sword. So just to call out a few of the things that we're trying to balance alignment with as we help to curate the common measure set and select measures, we got all this going on. We've got, in the state, we've got multi-payer primary care initiative, Medicaid transformation. There are all the many things happening at the federal level. There's what NCQA is doing. There are legislative requirements. So I would just call out alignment is not simple. It can seem simple from any given little angle, but there's many things in this space, and aligning is it's hard. Challenges on the next slide. First off, that kind of conflicting alignment piece. How much to keep something stable versus when to change it? What's the right size of these lists? And I think the theme on that is always like, there's too many measures, but my special measure should stay on it. So we all just have to balance those things out. And then really looking at the equity role. One of the things that we've been thinking about is stratifying measures by performance in different populations and making sure that we are trying to reduce those disparities as well as improve overall performance. Sorry for talking fast, but I did want to make sure we had time for the panel. I'm open to questions anytime now or later. And we've got some links here to the total common measure set and to the PMCC information.
Thank you, Emily. As a data geek, I do appreciate having all of those available on the website. And are you okay with folks emailing you after the fact with questions as they come up? Perfect.
Absolutely.
Thank you. So now it is my pleasure to help us transition into our panel. I am going to pin our speakers so that we can see them. There we go, perfect. So I am joined today by Dr. Edwin Carmack, Medical Director and Hospitalist with Confluence Health and a graduate of the University of Washington School of Medicine. Dr. Angie Sparks, Chief Medical Officer, Community and State at United Healthcare Washington and past president of the Washington Academy of Family Physicians, also a graduate of the University of Washington School of Medicine, and Dana Weatherly Wilson, RN, Manager of Value-Based Healthcare for Pro-Liant Surgeons, and elected this year as Port District Commissioner for her county. So thank you all for being a part of this panel. We will go through a bit of an intro if you wouldn't mind spending about 2 or 3 minutes giving a background of you and your organization, and then go into questions. And for folks on the call, please write your questions into Q&A and we will do our best to work through those. So Edwin, we will start with you.
Thank you. So it's nice to be here. I am, as you mentioned, a hospitalist and the medical director of quality and population health. I'm at an organization called Confluence Health. We're based in Wenatchee. We have specialty in primary care as well as hospital inpatient care and ER spread over north central Washington. So it's about a 12,000 mile geographic area. Largely rural, and we have about 250,000 people in our service area. Is that sort of what you were looking for to start with? Okay.
That's perfect. Thank you. Moving on to Angie.
Hi there. I'm Angie Sparks. As Jenny said, I'm a family doctor, and I represent United Healthcare Community and State Plan. We have the good fortune to be the payer for 300,000 of our Medicaid and dual eligible members in the state of Washington on behalf of the Healthcare Authority. And value-based purchasing is something that we're very interested in and have been doing for several years. And all of the challenges and exciting things that Emily has talked about, we live that every day, and really appreciate the partnership with the Healthcare Authority in trying to reduce as much as possible the complexity of trying to do these programs well, making sure that we are measuring what matters and making sure that our government programs recipients in the state are getting the highest quality of care that they deserve.
Beautiful, thank you. And Dana?
Hello, can you hear me all right?
We can.
Well, first of all, thank you, Jenny and the foundation for inviting us to come to be on this panel. I appreciate that. I work with Pro-Liant surgeons. They're celebrating their 20th year this year. They were a privately owned physician practice with orthopedic, spine, ENT, general surgery, ophthalmology, OBGYN, and urology, and more. We have over 450 providers with 200 board certified physicians, over 100 locations across the state, and we've helped more than 800,000 patients every year to get healthy. Our geography includes 123 locations from Bellingham to Tacoma. And we've been part of bundle payments, different things since 2015. So we are very excited to be part of this conversation.
Thank you. And I saw 2 comments that folks are just seeing myself. I hate the idea that it's just my face being giant on everyone's screen. So on the corner up here, you should have a view option and you can switch between active speaker and gallery view. And so if you switch between those, you should be able to see our 3 panelists as well as myself. Okay, so Edwin, we'll start with you. From your perspective, how has measurement alignment progressed in the last 5 years and then in the last 12 months? Are we seeing progress? Are we seeing more alignment, or not necessarily any change?
I think over the past 5 years, there's definitely been improvement. I've sort of been heavily involved in this work for about the past 3, so that's sort of my perspective. I think when I first started, there was a lot of talk about, we need to get measures aligned more. I think I am seeing progress in that. I think, and maybe over the past 12 months, we're moving beyond a little bit more just talking about we need measure alignment and actually seeing some of that. There's still a tremendous number of measures out there, and that is a challenge, but I think the alignment is improving.
Yeah, that makes sense. And Angie, how about you? What has changed in the last 5 years, last 1 year?
Yeah, I mean, if I look back to 5 years ago, we were just getting started with quality measures. As Emily pointed out, it was 2014 when we started moving toward the common measure set. I think it has been a very helpful tool to get folks aligned. Where I'm finding current challenges are sort of, the measures might vary depending on who the payer is. So different programs, different stakeholders, as was outlined in some of the presentations, and even with the same measure specification, data visualization, who is the intended audience, who are you trying to influence with the data, all of that leads to additional complexity. So while I think that the measure alignment has improved, I'm not sure that we're making as much progress on simplification and complexity as we could be.
And Dana, how about you?
Yeah, I agree with both Angie and Edwin with that concept that I think since I've been with Proliance in 2015, there's been a big kind of shift that we're aware of the different measures, but with different payers, different, like even different site of service. There's, like we're surgeons, so most of these quality measures, they don't, the ones that you guys have, the comments that they're not applicable to us. And so we've had to internally kind of create different quality measures, and we're really working to develop a streamlined process that we can share back with payers and employers and different things like that. And I think everybody, I believe, we had a lot of momentum going with all of these common measure sets, and then the pandemic forced us to pivot and focus on something else. And then I think it's created different measures that we didn't know we were aware of. So we've lost momentum.
Yeah, that makes sense. And when you think, Dana, about quality reporting in your organization, what is your biggest pain point?
The multiple EMRs, and an epic is not an epic is not an epic. And then, data that's gathered within the hospital or in our surgery centers. That's been a pain point, that there's lack of transparency across, all the players in the healthcare landscape.
And Edwin, how about you? What is Confluence's biggest pain point?
I think there's 2 or 3 big ones. One is the resources to report this within the organization to sort of handle, the multitude of reports we get from different payers, which are typically in sort of an Excel format. They're not in our EHR. Mm-hmm. And it is a struggle to get that information or those chase lists into our EHR. And if it's not in our EHR, it's really not as actionable by our staff. They can work outside our EHR, but really, if we want to contact patients, if we want to message patients, if we want to try and get them in, it has to be in the EHR. And so we're working to try and have a process where we can get some of those lists into our EHR to make it easier for our staff to actually do this work. And then I think, we struggle with resources to handle the amount of data. And it's our pull as a healthcare organization, as a provider, is not always focused just on our data. There's lots of other pulls for resources and people. And so some of it is just the resources to handle the volume of data that's coming in and going out.
Angie, how about you? What is your biggest pain point you've seen at United?
Yeah, I think what it is really trying to figure out that balance that Emily talked about between wanting improvement from a baseline and then wanting to actually move the needle on a population as a whole, right? And how do you make sure that the incentive is resulting in the outcome that you're looking for the patient population, rather than maybe creating a different financing stream, but isn't always leading to that value-based improvement that you're wanting. Because this is all around contracting and reimbursement and things like that, there is there's some challenges with that. And then the other one is just the data issues that we've talked about. And, you know, if the measure changes, having to sort of rebuild and re-resource and realign all of the different complex systems, contracts, and things that you already spent a great deal of time putting together, and then working again with your medical groups to kind of say, okay, there's been a big change. Now we're going to do it differently. And I think that pace of change can be really challenging as well. And again, lead to more complexity rather than simplification. I really appreciate the comment about anything that we can get into the electronic health record, which is where all of our care teams live all the time, is really helpful. But there's that interoperability challenge too that makes it really tough. We have, as the healthcare authority is well aware, across the state, practices at different levels of being able to even exchange information digitally. Some are on fax even to this point. And so you're creating redundant systems and different ways, which are very inclusive, but then are limited in how much resources they take because you're doing the same work several different ways.
I wanted to comment on what Angie said, that I think if the information from the EHR or the data source could have like a bi-directional feed, so then whatever, you know, somebody did something to assess an issue, then it's fed back over to the data repository. So then there's a spreadsheet or something that shows what was done versus trying to track it in multiple locations.
Yeah, that would be ideal. Dana, do you think we'll ever get away from using faxes in healthcare?
Well, if I have my way, it will. You know, the stories, I sent the fax. Well, that's fine. I didn't get the fax. Can you send it again?
Yeah. It's a huge barrier. Angie, how about you? Do you think we ever will get away from faxes?
I really do. And I think there's actually an imperative to, and our national CEO has really talked about the paperless initiative in healthcare. We are a great source of waste as an industry. And paper is one of those, but also just if you think about sort of lean principles, that piece of fax paper gets so much handling and has so much potential to be lost that it really isn't serving as well. That said, we also need to figure out how to help folks, and we need to honor difference in our populations. There are also not just clinical teams, but the reason they do that is because the population that they serve really is in a paper-based environment still. So we can't unilaterally make that change. If it was easy to do, we'd already done it. But that is the ultimate intent. Yes, absolutely.
Edwin, do you think we'll move away from faxes?
I will speak as a quality person and then as a hospitalist. So as a quality person, I certainly hope so, because really for us, when something comes in as a fax, it gets into the media tab in Epic, which I consider a black hole because it's not very searchable. It just, and everything gets dumped in there. And so it really is not useful information that you can get back out. As a hospitalist, when I'm seeing a patient up on the floor, when the records come, it honestly is easier for me to have it on paper and flip through it, because it just currently the way it works. And that's just, you know, my experience. But so it is, there is that component to it. There's a lot of like, it's in the electronic record and then print it out and use it and then toss it, which is not great, to Angie's point.
Yeah. Edwin, how has the common measure set shown up in your work with Confluence Health?
So that's an interesting question. So I see the common measures in our Medicaid contracts, and then we participate in the Puget Sound High Value Network, which is sort of a state employee ACO, I think is the best way to characterize it. And so I see those measures in those contracts. It is nice that it's sort of a limited set of measures. I will say that those populations are not where we have the most financial risk. And so, you know, we pay attention to those measures, but it's not necessarily drivers for us at this point. It is something that is on my radar as we get better at population health. And, you know, we focused mostly on our Medicare population because that's where we have the financial risk in our organization. As we, you know, kind of refine how we're working with our Medicare population, expanding sort of our population health efforts and getting better at those, at taking care of those populations, I do anticipate us diving into some of those measures more.
And Angie, how about you? How has the common measure set shown up?
Yeah, I feel like it really has helped alignment. I don't know what we would do without it, quite frankly, because it really is like that convening of having everyone sort of on the same page of what are the measures that matter. I think is helpful. There are quite a lot, as was pointed out, and depends on what you're doing. But as Dr. Carmack just pointed out, are the incentives aligned for different products, right? I do think CMS and Medicare Advantage is seeing real success in their value-based programs because there are the incentives there for Medicare recipients. But I also worry a bit that for other governmental program recipients, like Medicaid recipients, that means that the focus on the quality of their care or collecting their data, which is much more difficult because there's not the same level of financial incentives aligned to it, really perpetuates health disparities to some extent, because the folks whose data is being measured and focused on really are the folks that their payer pays more for. And that's just a real challenge of the structure of the healthcare system in general that I don't know that we're going to solve today. But just being aware of it and trying to figure that out, I think, is important. But just knowing that in, you know, our Medicaid contracting, it can be a real challenge when so much of an organization's energy is focused around their Medicare Advantage population.
Point.
And I'd like to speak on that. Like, Reliance has participated with the CMS BPCI program for total joints and spines, and we're currently in some commercial programs. And like I said earlier, the common measure set is not applicable to us because of being surgeons. The one thing that I think is interesting, like talking about any of the Med Advantage plans, because we really take it serious to deep dive into any data we get, but Med Advantage is like in a deep dark hole that we don't have access to our patients' data. And I can't seem to figure out where to get it.
It's a theme I've heard a couple times. Deep dark holes of data, not being able to have it go anywhere.
Sometimes called data lakes.
Mm-hmm.
Yeah.
Yes, very true. I've appreciated in the other speakers the focus on equity. I think that's been really nice to hear as a theme. How has data, I'm curious for everybody, how has alignment helped or hindered your organization's work to provide or pay for more equitable healthcare? Edwin, we'll start with you with Confluence.
So I think the focus has been good. I think what we learned as an organization with the pandemic was, I mean, we all knew there were health disparities, but it really highlighted them, and I think opened the organization's eyes to the extent. What we discovered first was that we didn't know the race and ethnicity of a significant portion of our patients. And that actually was the biggest barrier to understanding what the disparities in care were, is we didn't even know who our patients were. So we actually, this year, as part of one of our organizational goals and on sort of our internal quality dashboard, one of those has been to capture race and ethnicity in our EHR and reduce that percentage of patients who don't have that documented. And we're now down below 5%, which was our goal. And that is great. I think what I'm looking for, we're starting to develop some data internally about where some of those disparities are. For example, there's a greater disparity for us in colon cancer screening than in breast cancer screening. But we also have some data around like referral rates to palliative care. I think what would help as a provider, I can start tackling some of those things and I can pick the one that I think is important. But I think as a state, it would be really helpful to start having some consensus around, as we understand who our patients are, what are the disparities that we should raise to the highest level to start with. There's obviously lots of disparity, but we're going to have to start picking a few to work on first. And I think doing that on a statewide level, as opposed to me as an individual system picking one, would be really helpful.
Yeah, that's a great idea. And Dana, how about you?
I totally agree with what Edwin said, and we're building trying to kind of make our own common set measure set internally and building that dashboard and being able to pull ethnicity, age, that type of thing. And I think the things that we've sort of overlooked is we have the patient's zip code. So we could do some risk stratification just based on that of understanding. And I think, it's kind of new to the market and understanding what we have, but I think we can do something with the information we have. It's just trying to figure out how to do that.
Yeah.
One other thing, I think with the pandemic and the payers doing the parity about paying for telehealth, I think that has provided patients access to telehealth or Zoom or things that maybe didn't have access to transportation, that live, someplace very rural, that they're able to access healthcare and get a consultation or something like that. And that makes me happy for Washingtonians.
Yeah, Angie, how about you?
Yeah, I mean, United Healthcare is fully committed to health equity, as defined by CMS, actually, on our recent presentation. What I've noticed in working in quality as we're having this transformation, first, your question about alignment, being aligned on the whole population of the United States or the state of Washington is very helpful for the aggregate data, and making sure that that's accurate, because if you're going to disaggregate the data, if you just disaggregate data and make smaller parts of something that's not currently accurate, that's going to be a problem for the population. So I think we needed to do that first. In the way that we were incentivizing the whole population measures, there really has been this tendency to focus on, and I'm just going to say a weird phrase, the quote, low-hanging fruit, or actually people who are closest to success in the quality. And when you think about that approach, I think that really does inadvertently advantage parts of the population who are already fairly well resourced. And so that's where that disaggregation becomes so important. And others have mentioned the data issue around self-identification of race, ethnicity, language. And we do need to be doing that. That data quality needs to get a lot better. And a lot of that is building trust with those populations. The other thing that I think is tempting in quality work is to have kind of a distanced approach to it. So what's great about some of these data measures that we love is we can just do all that with computers and we don't have to bother anybody. But health equity work is more hyper local than that. It's really kind of the opposite of what we've been doing in population level quality. So it's a totally different approaching the community. So when we're saying, well, we want the state to tell us like what disparities we're going to work on, I think that's by zip code, as Dana was mentioning, because it's going to be different depending on what county, community, even parts of cities that we all live in, that you're talking about as to what the health disparities are. There are probably some broad level things, but really we need to go to the communities and ask them. That's the other real challenge, I think, in quality improvement work in health equity is we are so centric in, we're going to go to the evidence, we're going to find out what works from other places, and then we're going to tell folks what the best practices are. And this is the opposite of that. We need to convene groups to tell us what are the needs of this community. We've used the data, but we don't have story and we don't have community input. So I really loved in the CMS presentation how they were talking about bringing the voice of the consumer, bringing the voice of the patient into a lot of these discussions, because it has been somewhat missing as we were building our data systems and trying to get everything aligned, I think we have a lot of opportunity for improvement, and it's really exciting, but it's early days. And we want to be careful that we don't perpetuate some of the stuff that we were doing before. So there's kind of our current president, Mark Johnson of the Academy of Family Physicians, in his acceptance speech said, one of our national president's quotes, which is, when you say quality, we say health equity, which is, you may be continuing some of those old approaches that really advantaged the folks that already were fairly close to achieving that quality metric. And we might find actually that if we focus on the folks with the highest needs to get there, we would actually have this like multiplicative effect. But we need to do all that research. We need to collect all that information. We need to have that available. So we're all in this together working on it. And I think it's really exciting times.
And that is a beautiful way to end this panel. Thank you, Angie, for that sentiment and bringing it back to health equity. I appreciate that. And there's no quality without health equity sentiment. Any closing comments from others? All right. If none, I will extend a warm thank you to all of you and unpin you, hopefully, from this, and then turn it over to Nick.
Thank you, Jenny, and thank you to all of our panelists. I think I really appreciated today's conversation. I know we've all heard the phrase, if you can't measure it, you can't manage it. And when it comes to providing value-based healthcare, we all want to provide equitable healthcare to all of our patients, but it's really that question about how we measure it that makes things get complicated. Some of the key concepts that I heard today from our speakers include using a collaborative and iterative process as we're choosing metrics to measure, and ensuring alignment and equity throughout the process. I think those are the things that I'm going to be thinking about as we go on from today. I hope everybody was able to take away one key piece or one key point that they can bring back to their own organizations to create action. And we will also be sending out the slides and a recording of this webinar after the event for you to review the resources that we've provided. Thank you to Tamira at CMS and Emily at the Healthcare Authority for providing some of those resources. Yes, Sharon.
Nick, yeah, there is still one unanswered question in the Q&A. It says concerns regarding pandemic impact on cancer screening combined with HEDIS measurements, how to rectify. So I don't know if anyone wants to take a try at answering that question, but it is still there.
A couple of thoughts. I just want to add to that, because this is Angie speaking as Angie Sparks right now. I just want to be clear. I'm involved in a study through the University of Washington about home screening for human papillomavirus. Current barrier to that being FDA approval, and so trying to get some research on board. But I think anytime we can bring the cancer screening to the patient rather than making them go somewhere for it. And uncouple it from, you have to have a well visit. And this is where fee for service really doesn't serve preventive care well, because there's this implied time and place for that service. But if it can happen when you're at the dentist, or it can happen when you see your surgeon, or it can, you can be reminded throughout your health journey, and then do it when it's appropriate for you. I think that would be very helpful. But whoever asked the question, thank you so much. Please continue to ask that question, because we have seen real declines, which are going to have real impact on cancer incidence, particularly for completely preventable cancer, nearly completely preventable like cervical cancer, because vaccine rates also are a huge concern. Great question.
Yeah, thank you, Angie, for coming back on for the last minute question. And then just real quick before we close, this is a reminder that this was our third webinar in our value-based care change in action series. And in October, we will be revisiting the fourth out of four, aligning payer strategies for population health. So last year we had a conversation that included the HCA and other payers. And this year we're going to be revisiting, seeing what we've learned since last year and how we can drive action towards value-based care. That webinar will be on October 6th, so please either save the date on your calendar or look out for more registration information from us. But thank you everyone for attending, and I hope you enjoy the rest of your day.